Hey there, well, good afternoon and welcome to our second episode of Ashgrove TV. I'm Stephen Bruce. Claire Short will be joining me. We are the husband and wife team that runs the clinic in Higham Ferrers. Both of us are osteopaths, and I think, Claire, we were going to answer patients' questions about knees today, were we not?
We're definitely going to talk about knees. And I see you've got a knee as well. I've got one here. And we're going to be talking, first of all, about ligaments and ligament injuries, and also about arthritic knees. So,
do you think, the reason, before you go on about this, nobody in our audience, none of our lovely patients in Higham Ferrers and Northamptonshire, wherever, none of them really want an anatomy lesson, do they? So why are we going to talk about ligaments, for heaven's sake?
Well, we're going to talk about ligaments partly because I think if you understand a little bit about the anatomy of what's wrong with you, it helps you understand what to do to look after yourself, and also what to do the rehabilitation, or as in, I saw earlier on that we've had a question in already about surgery. It helps you make decisions about whether to have surgery or not. So I think we don't have to go into great details about the specifics of ligaments, but just to have a rough idea. I like to think of them as the seat belts of the knee. They kind of hold everything in place. But if they get torn, your knee isn't held in place any more than you are driving a car that has an accident without a seatbelt. Yeah,
but the other side of it, what I thought was useful is that people bandy terms around, and bandy is a pun on what happens to your knees, I suppose, not meaning to use bad puns, but people use lots of terminology about knees, and we allow it to wash over us, and we think, oh, there's an ACL injury, oh, he's got a meniscal injury, all that sort of stuff. But we don't actually know what that means, do we? Just as last time we talked about ruptures to ligaments and tears to ligaments, and they can sound really nasty, but if we try and, I overuse the word demystify, but try and demystify what's going on in the knee, it might help people.
I agree. I think it's really important to understand what your injury is, even if you don't know the details. And as you say, we looked at tendons last time and the ruptures, and you had your beautiful example of a tendon. And I think it's interesting and useful for people to understand that ligaments are much tighter. They really do hold things together like a seatbelt, whereas a tendon, if a tendon were a seatbelt, it would have lots of give in it, wouldn't it? It wouldn't really hold you in place.
I read a piece of information some time ago that said that the strength of the anterior cruciate ligament, the ACL, is, I think, the breaking strain is 2,200 newtons. Now, I don't know what that is in terms of how many elephants pulling on a rope, but it's a hell of a lot. It's really, really strong. The ligaments are like steel wire rope, aren't they? They are phenomenally strong. They're probably stronger than steel wire rope by cross-sectional area.
Well, when we run dissection courses, it's actually really hard to cut through the ligaments in order to get into a joint. So if you were, in our knee joint, here's a ligament here. If you were cutting through that with a scalpel to get to the actual joint of the knee, it's really, really tough. They're not just floppy little half-hearted.
Which always begs the question, doesn't it? How on earth do we injure the ligaments? Because they are so strong. But of course, it's very hard to take in the amount of strain that is going through such a complicated joint as this. There's all sorts of directions. People think of the knee as a hinge, but it isn't just bending, is it? It's bending, it's rotating, it's sliding, it's doing all those things at the same time. It's a very complicated joint held together by a number of different principal ligaments.
Do you want to, since you've got a lovely lovely close-up shot of the knee, do you want to just go through the main ligaments and point them out on your model?
Yeah, with this model, it's somewhat unhelpfully, everything is the same colour. So this is the front of the leg. This is a right leg. You can tell that because you've got the little thin bone going down the side, sometimes called the splint bone, but otherwise the fibula. But on the front, this is actually a tendon, because this is the tendon that goes over the kneecap, the patella, which slides up and down in this little groove on the thigh bone, the femur. And we'll probably come back to talking about patellas in a little while. So this one's actually a tendon. But at the sides of the ligament, we've got what are called the collateral ligaments. So we've got the medial, the inside collateral ligament, and we've got the lateral collateral ligament attached above and below the joint. And essentially, they stop the knee, or prevent the knee from going too far, in that sort of direction. And we'll often hear about sports people who have damaged or even ruptured those ligaments. And of course, they're very important, because without them, you've got uncontrolled sideways movement in the knee. And then inside the knee, again, the colours aren't helpful on this model, but the bits around the bottom here that are perched on top of the shin bone, the tibia, those are actually the meniscus, which of course very unhelpfully we tend to call cartilage. So when someone says they've got a cartilage injury in the knee, this is what they're talking about, but actually it's the meniscus. And that goes all the way around the edges of the bone there, as you can see. And then you've got two principal ligaments, the anterior cruciate and the posterior cruciate. And this knee has a completely ruptured anterior cruciate ligament, which is helpful because it means we can see the posterior cruciate more easily. So there is the posterior cruciate ligament, and that posterior cruciate ligament is designed to stop forwards and backwards movement of the tibia and on the femur, while the anterior cruciate does the opposite. Is that the sort of thing you wanted to hear, Claire, or is that
Yeah, could you just show us the menisci again? If you open up the knee and you can see the actual discs, I think that's
right.
The circles of them. I think that's beautiful.
These two little circles, these are the menisci, the meniscus either side. And when someone says they've torn a cartilage, it's going to be this one that goes, and it'll be somewhere around the back here. And it might just lift up. There might be a flap in there that can be repaired, or it could damage it completely and separate completely from the bone. But that's what we're talking about with cartilage injuries to the knee. But as you can see with the cruciates here, one of them, the posterior cruciate ligament, stops the tibia, the shin bone, from going backwards. So it's actually very, very important in stabilizing the knee. The anterior cruciate ligament stops the shin bone from going forwards, but it also stops it from twisting and rotating. And that's the one which is particularly important for multidirectional sports, since football players, basketball players, rugby players, they're the ones who are, commonly the ones who will injure that anterior cruciate ligament. There you are. That's Anatomy 101 for today.
Well done. You got a 2 out of 10 for that.
Thank you very much.
So the thing that I think is really important to understand is that when you have, is generally what we see are skiing injuries and football injuries when the ACL is damaged, isn't it? Very often they are completely ruptured. So it's, as you said, an enormous amount of force going through the knee to rupture that ligament. But we had a member of our team who did exactly that, skiing, the osteopath Ruth, a few years ago. And we were all fascinated because until somewhere around that time, they were always operated on. And if you had a rupture of the ACL, you had to go for surgery and they would repair it. But she was told they weren't going to operate, and all of us were horrified. But it is the new thinking, isn't it?
Yes, yeah, it is. Yeah, and has she recovered fully now? I can't remember. I haven't seen Ruth for a long time.
Yeah. It was really interesting. She was actually back to work fairly quickly. She wasn't pain-free, but certainly she could move around, and she did feel that there was some instability in the knee. But she was, of course, all of us were running around giving her exercises and treating her and what have you. But yeah, she was given lots of stability exercises. I think she and Jay worked quite closely together to get the strength back through the knee without having the ACL attached.
What we want to get from this, we actually had a question, didn't we, from Tony, who says he's got an ACL injury, but the consultant won't operate, and you've answered his question, is that normal? But what we want to do for our audience is to reassure them that sometimes doing nothing, or not doing nothing, but not taking the drastic route of surgery can be the best option. And pretty much, these days, every surgeon will avoid surgery if they can, because to get to those ligaments, you've got to cut through so much important tissue to get into the knee. And I can't remember the details of the paper I read some time back, but every time you cut into somebody's knee, you are increasing their likelihood of arthritis later in life, aren't you? And they want to minimise that, because that just creates further problems down the line. So if we can fix things without surgery, that's great. Yeah. What did we do specifically for Ruth? Was it just exercises, or?
Yeah, I think we did a fair amount of hands-on treatment. So to try and get the tissues that were terrified, and I appreciate that your body, your muscles and ligaments are never really terrified, but there's a sense of shock that goes through the body, which means that the muscles are tighter, means the fascia just doesn't feel like it's as movable as normal, and that there's inflammation in the area. So we did lots of hands-on, lots of very gentle hands-on, and also treated her lower back and the other leg, because of course they were, I'm leaning across to demonstrate, but they were taking more weight. So we needed help with the compensation patterns she was building up. And then to refer her to Jason, our senior sports therapist, to get the exercises that would keep her really strong.
But of course now we would also refer to Jason or one of the others for laser therapy, because laser is phenomenal at healing tissues like this. And it penetrates really well into the middle of the knee there, where it would need to be to sort out those ligaments. I guess one thing that people might be worried about is knowing what it is. Have they injured the ACL? Have they injured the posterior cruciate ligament? Have they injured the cartilage in the knee? How are they going to know which one is the thing that they've got to deal with?
Well, ordinarily you would start off with us, wouldn't you? Or a consultant, or possibly a GP, doing very simple orthopaedic tests. Yeah. We've got a nice bunch of tests that will check each of the ligaments on the side, but also the posterior and the anterior cruciates. Yeah.
And I don't want to be, I always say this, I don't want to be rude to any of our GP friends. I mean, they are phenomenally highly qualified in what they do, and all of them, to become GPs, are phenomenally experienced, but they don't do much in terms of musculoskeletal injuries. So some of them, probably the vast majority, won't be as good at someone as a physio or an osteopath or an orthopedic consultant in making these assessments, because none of the tests are 100% accurate, and you need to be really skilled to interpret them so you're treating the right thing, don't you?
Yeah, exactly. And also our understanding of which tests are effective changes over time. And we learn new ones. And of course, because that's our speciality, we tend to keep up to date.
Yeah, I'm always not puzzled, struck by the knee, because there is a particularly good test for assessing whether the anterior cruciate ligament is damaged, is ruptured or damaged. But of course, if the posterior ligament is damaged and not the anterior, then the knee will start off in the wrong place, so you'll get the wrong impression from that test. And you've got to be very careful to make sure that you're doing it correctly. And I'm not trying to say that we never get it wrong, but you do need to have that level of expertise to be able to make this assessment accurately and get the treatment right. Well, do you remember what's the rehab time for knee injuries, particularly cruciate injuries? It's not quick, is it?
I'm not sure about. I think Jason would be better placed to answer that question, and he's going to be on the show, I think, for the next one at the beginning of October. And he'll be able to answer that. But from what I remember, so generally I would do the hands-on stuff, same as you, and then refer to somebody like Jason for the rehab, because that's his speciality. But I would expect somebody to be, fairly well out of pain and stable after at least 6 weeks.
Yes. Yes, and I would expect that you might be looking at as long as 6 months or even longer before you've got full restoration of strength and stability in the ligaments. But as you say, we want to get them out of pain as soon as possible, and laser, hands-on therapy, and so on is going to be a major part of that.
And also do your exercises.
Yeah, and doing the exercises. But one of the things that you and I find with patients, Claire, is that we had three types of patients, I suppose. You get the ones who do as they're told. You get the ones who don't do anything at all. And then you get the ones who think, well, if that's a good exercise, then I must do much more of them. I should do them more and harder and heavier, and that'll improve me quicker. And there's a nice Goldilocks spot in the middle, isn't there? Is doing what you're told is right. If you overdo it or underdo it, you're just not going to get the benefit.
I don't know what you're talking about. My patients always do as they're told.
Yeah, that's because they've had experience of your pointy elbows.
Because they're scared of me.
Yeah. What I suppose we can't really go into exercises here because they would be specific to the particular injury concerned, wouldn't they?
And I'd really like to cover that next time with Jason, because he'll be in the studio with you and you'll be able to go through some exercises very specifically.
Yeah. Another of my hobby horses, there are many, as you know, Claire. You like real horses.
Are you about to rant?
You like real horses, and I just have hobby horses that I rant about. I was talking to a chap a couple of days ago. It was at the airport, actually, and he was on the crutch, and he'd clearly injured one of his legs. It turned out it was his knee, but he had his crutch in the wrong hand. And we ought to do a show on this, because I blame, America. Hugh Laurie, I blame him on House, that American medical soap, because he used his crutch in the wrong hand. And everybody instinctively does this, unless someone who knows better, like their physio, their osteo, their chiropractor, unless someone like us tells them to do it otherwise. And it drives me up the wall, because we look at the body as a whole, don't we? And if you twist the body in the wrong way, you're compounding the problems. You mentioned treating the opposite leg because there's a knee injury. Well, if you've got your hand and leg moving on the same side at the same time, this is using the wrong hand and crutch, then the twist is wrong in the body, and it's going to create other problems elsewhere. We'll have a whole show demonstrating how to use a crutch.
I think most people don't realise as well exactly how much you're affecting the good leg when you've got an injury. So it's no secret that I had a broken leg for 3 years, thanks to your motorbike.
No, because you won't stop going on about it.
And so I was on 2 crutches for 5 months and then 1 crutch for another 6 months. And the pain that I got in the front of my good leg, the front of the thigh, just from weight bearing on that side, was really quite extreme. And everybody in the rehabilitation is always so worried about the bad side. It's very easy to forget that the good side is having a hard time too.
Yes. Yeah. And probably we need to move on from this, but with any knee injury, because for long periods of time, people will offload the knee, they won't use the knee. The quadriceps muscles waste away so quickly. The quadriceps muscles, the muscles in the front of the thigh here, they waste away so quickly. Really important to keep them strong and ready to re-engage when you're fit again, isn't it?
Yeah, and they waste, I think, quicker than most muscles, faster than most muscles. They're very pathetic. Yeah.
I've got
arthritis.
I've got one here which I'm this is going to sound as though I'm taking the mickey. I'm not. A lady called Claire D has asked what is CMP? And she's put chondromalacia patelli. And she knows that's not right, but it's something like that. Because lots of people talk about CMP knee, and again we all nod and say, "Oh, CMP knee, what's that all about?" And then they say chondromalacia patella, and we think, "Oh, we still have no idea what that's about." What is it, Claire?
Well, luckily for me, or for us, I know what it is, even though I can't spell it. So chondromalacia patella is an erosion of the back of the kneecap. So the back of the kneecap has got a lovely, beautiful, smooth layer of cartilage on it. And if you have problems with your knee...
Well, you keep talking.
Exactly where it is. Yeah. So if you have problems with the knee, that beautiful layer of cartilage starts getting eroded. And you and I have seen in some of the dissections we've done, really, really deep channels where it's been engraved into the cartilage on the back of the knee.
Yeah, and it runs in this little groove here on the femur, doesn't it, on the thigh bone, and both of them are beautifully smooth. But you can imagine, if you have 2 cheese graters rubbing against each other, then it's going to be jaggedy and horrible and painful. And there's a a nasty, horrible test we can do to assess whether chondromalacia patella is present. But it is a nasty thing to do. What do we do about it, Claire? Because we're not going to go in there and smooth these things off with sandpaper, are we?
Well, no, this is the wonderful thing, is that even though it might be diagnosed, it doesn't necessarily mean that you have to live with pain. If you can stabilise the knee, so if you have got, I was going to put those fingers up, but I'll change my mind. If you've got 2 grooves there, or even there, you've got those 3 grooves on the cartilage, and then those 3 sticky out bits on the knee, if you keep them in line, you should be fairly pain-free. It's as soon as you start moving the kneecap into a different groove that you'll get pain. So if you stabilise the knee, you keep it strong rather than just resting it, which is what is often prescribed for CMP. Then you keep it healthy. Yeah.
Okay, so there's hope for people who've been told they've got chondromalacia patella, which sounds almost terminal, doesn't it? Because it's such a horrible expression. And you wanted to talk about arthritis. We've got 10 minutes left, so give us your 10-minute lesson on arthritis.
So the thing I love about when people are diagnosed with arthritis in their knee is that if you can strengthen that knee, there is an enormous chance that the pain will reduce and that you will get a huge amount of the function back. And that if you sit on your bum saying, oh, woe is me, I've got arthritis, I need a knee replacement, the chances are you'll end up needing a knee replacement. And that doesn't mean to say that you have to go to the gym. You don't have to go and pump iron every single day. But there are exercises you can do, again, to keep the knee strong, to stabilise everything. Am I ranting?
No, not at all. I'm thinking back to when we had that wonderful sports and conditioning therapist, Claire Minchell, thank you, Claire Minchell on the Academy of Physical Medicine show, and she talks about how to strengthen most effectively, doesn't she? And she gives lots and lots. She gave lots and lots of exercises that anyone could do at home using. It could be shopping bags or anything else that you can use as weights. But she also talked about the efficiency of strengthening muscles, and it was based on doing probably 5 repetitions, but with a weight such that you could not physically do more than 5 repetitions of that exercise. And you only needed to do 15 in total for the session and 45 in total for the week. So if you broke that down into 3 sessions, you'd do 15 today, leave it a couple of days, do 15 more, then do 15 more. That would be optimal. Go on.
We've got a whispering going on your mic, just so the tech team know. When you're talking, there's a whispering noise on your mic.
Right, I mean, it might be the sound of the rain howling down outside, I'm not sure.
Oh, possibly, okay. Yeah, and I agree that there's a lot you can do to strengthen it, just to strengthen an arthritic knee. And loads of it you can do at home. It doesn't mean that you have to be in having a treatment all the time, but you need to get professional advice about which exercises are going to work and what kind of weights to start with. I think. But
I'm not saying for a second that you have to follow Claire's advice to the letter, because any sort of resistance exercise will be contributing to strength. It's just that the most efficient way is what she described.
Yeah.
What about Paul's question about whether he can run on his arthritic knees or not?
Oh, well, again, I think if you've done really good rehab to get the knee strong, you'd be astounded at how much exercise you can do and how much you can use an arthritic joint if you're looking after it well, even after it's been diagnosed. So I have a lovely, admittedly, it's a hip story, not a knee story, but I had a patient who was in her 80s, a long time ago, who was petrified of having a general anaesthetic, really terrified. And she used to come to me once every 2, 3, 4, 5 months to have an osteopathic treatment. And we kept her away from the surgeon for 5, 6 years or so. And she would go back to the surgeon for a consultation. And he had said, looking at the images, she was desperately in need of a replacement. And there was nothing anybody could do to help her. But she was good for another 5 years just by having hands-on treatment.
You've hit there, haven't you, on a really key thing, that as people often say, we do not treat images, because images can give you clues as to what needs to be done. But, we don't treat a knee simply because the image says it's all raggedy and arthritic. We don't treat ligaments because the image says that there's some sort of discrepancy between the two ligaments either side. We treat the symptoms that the patient's got, because very often, well, if you scanned the whole population of the country, you'd find loads of people have got knees or ligaments like that, and they've got no pain at all and no instability. They're fine. They're just a clue for symptomatic patients into what sort of treatment might be beneficial.
And following on from that, I think it's really important as well to know that one person with an arthritic knee, say, 65-year-old osteopath, might have certain muscles that are tight, or a certain type of imbalance in the muscles around the knee. But a different osteopath of the same age with an arthritic knee might have a totally different pattern in the muscles. So when, if somebody says, well, I got this treatment, they treated this muscle because I have an osteoarthritic knee, it might be totally different for another patient who has tighter hamstrings rather than quads, or tighter or weaker glutes. I think it's really important to know that the treatment we do is so individual.
I suppose we ought to wind up. We've got 5 minutes, but we ought to wind up with just some sensible advice for members of our audience here who have got worries about a knee injury. What would be the first thing? I think we'd probably recommend, first of all, if it's not desperately serious, go through the RICE procedure, the standard rest it. That doesn't mean don't do anything. It means stop doing the things that irritate it for a period of time. Get some ice on it, put a compression bandage around it, and elevate the knee for, well, as long as you possibly can. But we want to avoid people sitting on a sofa for days on end. But while it's in that very acute stage, and probably we should emphasise that acute in medical terms means recent. It doesn't mean it's severe. It just means the injury's only just happened. While it's acute, offload it, elevate it, compress it, get some ice on it, and rest it. But then, if it's not getting better, then they need to get someone to assess it properly. And it's probably easier to assess a knee once some of the swelling has gone down, because virtually everything you do to a knee is going to cause swelling, isn't it? Yeah, definitely.
Yeah. And you're right, using ice and compression can be really helpful. And even when you've got an arthritic knee, sorry, I'm about to sneeze. Even when you've got an arthritic knee, sometimes using compression bandage just to keep the inflammation down can be really helpful.
And it's a weird thing, compression, isn't it? Because it doesn't seem to work for the reasons we think it would work. Sometimes it's just providing a different sensation to the brain, which either prevents the pain signals from getting to the brain or distracts the brain from those pain signals. It's very odd, isn't it? But I can't recommend laser highly enough for certain knee injuries, because I had a nasty knee injury not that long. Not nasty, it was a very, very painful knee injury, and I was on 2 crutches for several days, but I got laser treatment on that knee over a period of a week, probably every day for a week, but it's so much better now, and it actually it almost feels better than it did before I had the injury, which is kind of nice. What should we wind up with then? Because Sharon has said, why do my knees crunch when I squat? There's an interesting one. Lots of joints crunch, don't they? Necks, elbows, knees.
But I think a lot of them, they crunch for different reasons. Generally, a crunching joint is nothing to be worried about. My guess would be any knee crunching is most likely to be bits of CMP, just making generally it happens when you bend your knees, and it's because the kneecap is just crunching around a little bit. But on the whole, I wouldn't worry about crunching in most joints. I mean, obviously, if it's crunching and extremely painful and there's a chance you've broken it, that's a different story.
I think I would probably say if people are getting a clunking knee and they can feel sudden movement in the knee in certain positions, then it would be worth getting that assessed professionally, because it could mean that there's some instability caused by a ruptured ligament, and you don't want to leave that to get to the stage where maybe it dislocates or something like that. But yeah, crunching Sometimes crunching goes away with treatment when you can stabilise a joint, but sometimes it doesn't. But as you say, it's not the worst thing in the world, is it? Claire, we're out of time. So thanks. I mean, what we expect to do for most of these shows is that we'll have one of the members of staff from the Ashgrove Clinic in the studio here with me, and we'll talk about topics which are of interest to you. At the moment, we're doing this once a month, so I think we're doing it on the first Tuesday of the month. Is it Tuesday today? First Tuesday of the month. But if we get enough interest from you, we get more questions from you, then we'll do more shows just to help you understand what's going on with your body and let you know what the best course of action is when you need treatment. Anyway, that's it for lunchtime today from me and from Claire, and have a lovely week.